Okay, good afternoon all. Today we are going to see about uterine prolapse. Last class we have studied about retroversion of the uterus. Retroversion means that is the normal position, how the position has the and that is the position of the uterus. There is a change in the position of the uterus. Here means the uterine prolapse. That is uterine prolapse. Otherwise we called as displacement of uterus. How the prolapse means that is breaking that uterus has comes outside the vagina or sometimes just below the vagina. Likewise, we can say that is uterine prolapse. So you see the normal uterus, how the anteverted, anteflexed position, we can see here the normal uterine position. Then that is prolapsed uterus, you can see outside the vagina it has seen. The prolapsed uterus refers to the downward displacement of the vagina and the uterus. Downward displacement. Otherwise, that is the retroversion means the backward displacement. That is called as the difference between uterine prolapse and retroversion. If it has differentiate between retroversion or retroflexion or uterine prolapse or displacement. If any distinguishing characters is asked, you can write if the retroversion, retroflexion, you can say that is the backward displacement of the uterus, and in uterine prolapse or displacement of uterus, you can say downward displacement. That is the difference between uterine prolapse and retroversion or retroflexion. Okay, then next etiology. Etiology, your predisposing factors are then, aggravating factors are there in predisposing the acquired and congenital. Then predisposing factors come to, we can see about the predisposing factors. Congenital at birth. In acquired means during labor. Bearing down, that is we are giving the pressure, bearing down about forceps delivery. Then traction on the cord, breech extraction before full dilatation. Then predisposing, that is in puerperium, lack of exercise and bodily weakness. That is the muscle tone, that is the uterine muscles, the laxity of the tonicity of the muscle has lost. That is the repeated deliveries of childbirth. That is the elderly multigravida, more than 4 deliveries. Okay, then there will be the loss of that normal tonicity of the muscles. Then aggravating factors, increase in intra-abdominal pressure, abdominal mass, ascites, chronic cough, constipation, obesity, uterine fibroid. Uterine fibroid means that is a heavy mass that is growing inside the uterus. Then degrees of uterine prolapse. In first degree, we can divide into 4 degrees. That is the normal uterus you can see here. Then signs of prolapse, how the signs of prolapse is there. Then it has numbered here. In the picture, you can see 1, 2, 3, 4. It has numbered here. So coming to first degree prolapse, the prolapsed wall extend up to the cervix. You see, the prolapsed wall is extended up to the cervix. Then in second degree of prolapse, the prolapsed wall protrudes through the cervix but remains within the vagina. Protrudes towards the, you see here, protrudes towards the cervix and it will be remains within the vagina. In third degree, the prolapsed fundus extends outside the, here you see outside the vagina we can see a tip of the prolapsed uterus. You can see extends outside the vagina. In fourth degree, total prolapse or procedentia. Both the vagina and uterus are prolapsed. Procedentia. You see, whole uterus has comes out. Another name also displacement. If in questions may ask displacement of uterus, that is uterine prolapse, procedentia also. Procedentia if asked also, you should write the same answer. What is prosidentium? You can write it is the fourth degree. There are mainly 4 degrees are there, prolapse are there. The fourth degree of prolapse is called as uterine prolapse is called as prosidentium. In that both the vagina and the uterus are prolapsed. That is the prosidentia. Then clinical features, everything went etiological factors, what we have discussed earlier, that we can write down. Okay. Then symptoms, feeling as something coming down from vagina, especially when she is moving. Backache or dragging pain in the pelvis, dyspareunia. Difficulty in pass urine, more the strenuous effort, less evacuation, incomplete evacuation. Urgency or frequency of micturition. The woman may experience difficulty in passing stools and complete evacuation of bowels. Clinical examination, inspection and palpation, vagina, rectum and rectovaginal. Pelvic examination, both dorsal and standing positions. The patient is asked to strain. This helps to demonstrate a prolapse which may not be seen at rest. We can clinically how we can examine the inspection and palpation. I say no, if the 4th degree means we can 3rd and 4th degree we can see in rectum or rectovaginal. Then pelvic examination, both the dorsal and standing position we can assess. And management, that preventive, conservative and surgery. Preventive means adequate antenatal and intranatal care to avoid injury to the supporting structures during the time of the vaginal delivery. Adequate postnatal care to encourage early ambulance, to encourage pelvic floor exercises. General measures to avoid strenuous activities, heavy lifting, to avoid pregnancies too soon. Conservative, estrogen replacement therapy, Kegel exercise, pessary treatment. Pessary last, that retroversion also I had taught you. A vaginal pessary is an object inserted into the vagina to the hole of the uterus in the place. Surgical management should wait until the symptoms are worsened than the risk of having the surgery. The surgical approach depends upon the degree of prolapse, desire for future pregnancies. Often a vaginal hysterectomy is used to correct uterine prolapse. Then nursing management. Acute pain related to pressure or tension of the prolapsed uterus on supporting structures. You can read the interventions. Then second one, risk for infection related to prolapsed uterus as evidenced by decubitus ulcer. Then anxiety related to uterine prolapse. Okay, thank you all.